Okay. So first, we will talk about something about the USG basics. So nowadays, this USG has become like a stethoscope, like our earlier for a doctor, stethoscope was very important, and for every diagnosis, he will use the stethoscope. But here today, in a pain clinic also we use ultrasound most of the time for diagnosis purpose also, apart from the procedure part. In procedure, for guidance of the procedure, we use fluoroscopy and ultrasound both. But when the diagnosis part is concerned, we use ultrasound more than any other thing. So most of the time, this ultrasound becomes like our eyes, and also sometimes it can work as our ears. So when we are using, what is the when you evaluate by any investigation of a patient or patient's ailment, then we are using this USG, CT scan, MRI. In all these modalities, what we are doing, we are seeing the structure, the important structure which we are concerned in a section by section, piece by piece. Okay, so in different planes we make sections. Okay, so here you can see that there are three planes we know: Caroline plane, sagittal plane, and axial plane. So with ultrasound, we are seeing the structure in those planes only. But only difference is that we are not restricted to the exact planes like coronal plane. I can put the ultrasound probe just to 10-degree right or 20-degree left or 15-degree right, 15-degree left from the coronal plane, from the axial plane, or from the sagittal plane. So this is a positive part when we are doing a ultrasound, when we compare with the CT scan or MRI, because in CT scan or MRI the planes are fixed. Remember, plane and axis are not the same thing. Okay, axis is a structure which is there in our body where we are focused at that point. Say if we are seeing that structure in its length, then we will say that we are seeing the structure in its long axis. But in the same orientation, probe is kept in the same orientation, but it may be so that you are seeing another structure which is not along its long axis, and then we will say that for that structure I am seeing in a short axis manner. So axis is related to a certain structure inside the body where we are interested, but plane is fixed. It is either with our sagittal suture, coronal suture, it is sagittal plane, coronal plane, or axial plane. Okay. In ultrasound, of course, sagittal plane and axial plane is more used. Okay, either it is, of course, long axis or short axis, or longitudinal axis or transverse axis, short axis. But coronal plane is sometimes used while using in the neck part or in the chest wall areas. There only we use the coronal plane ultrasound. Otherwise, in most of the areas, it is the transverse plane, means short axis, and the long axis or sagittal plane. Okay, so and there are some pros and cons if we compare ultrasound with CT scan and MRI. So one positive point I told you, that with ultrasound these axes and planes are not fixed, or we can put the probe on the patient's body in any axis, in any plane. Okay, wherever we want to. So this is one positive point. Now there are multiple other positive points, like say dynamic examination. We can do a dynamic examination with ultrasound, but you cannot do the same under a with a CT scan or MRI. Patient cannot move there. Okay, but here if patient moves, you can see the probe placed on the patient's body. You can see that whether there is a I mean structure is moving or not in that way. So these are some positive points. What are the con side? Con side is ultrasound probe is very small and it shows a very small area. In with MRI or CT scan, you see a large area, but when you compare with the ultrasound, you see a very small area. Yeah, apart from that, the ultrasound beam cannot pass through a bone. So whatever lies behind the bone, you cannot see. So this is a negative thing. Con side. In simplified way, if I say that in with ultrasound, you can see to a certain depth. Okay, if in a superficial areas are clearly seen, but it is if depth increases, say more than 4 centimeter or 5 centimeter, when the depth increases, pictures become hazy and pictures are not clear. So this is a concept. So there are every investigation modality has some positive point and some negative point. So this is what I was saying. So from cranial to caudal, we can see cross section with a MRI picture also. Likewise, we can see when we are seeing with ultrasound in a short axis manner or transverse section, we also see the same thing, but in a small place. This is a medial sagittal section. So this is an MRI picture or say cadaveric section. So this is a sagittal picture. So in this way only, when we will get this picture only, but of a small part, when we put the ultrasound probe in a long axis manner on the patient's body. Okay. Now USG machine versus eye. So as I told you that USG machine, it is like our eye. We are seeing with this machine inside the human body. Now if we compare that few things like how the picture is formed. So here while we see an object, we are using light as the medium. That light is coming falling on the object, going to our retina and forming a picture there, and then it is processed in our brain. So here actually sound wave is that thing, it is not the light. So here medium is sound wave. So the wave which is forming the picture is sound wave. So sound wave is going and hitting the structure, and then sound wave is again coming back, and all are to the transducer. It is sound wave is produced from the transducer. It is coming back to the transducer. So here transducer is the emitter, is the receiver, and the wave which is forming the picture is sound wave, not the light. Okay, and then it is of course processed in the CPU or computer, CPU of the computer of the ultrasound machine, and then we can see the picture on the screen. Okay, so this is just for comparing that how the picture is formed. Now, as we understood that sound wave is the main thing which is forming the picture. Now sound wave is a mechanical longitudinal wave. It always requires a medium. If there is no air around you, if you speak, nobody will hear. Okay, so that means it requires a medium. So here also when the sound wave is produced from the transducer, medium is our body tissue is medium. It is placed on the skin, and through our body tissue it acts as a medium. Sound wave goes in, and then it reflects back from different surfaces, different tissue surfaces. It reflects back. Now sound wave is where from it is produced. So you have understood that it is produced from the electric. It is from electrical energy. It is produced from the emitter or probe. So ultrasonographic probe, okay, which is acting as an emitter. So ultimately it is forming from the electrical energy. Electrical energy is becoming the sound wave. Then so remember two phenomena. One is piezoelectric effect and one is reverse piezoelectric effect. So remember, this piezoelectric effect means here actually first you remember the reverse piezoelectric effect. Okay, reverse piezoelectric effect means electric to sound. Okay, electric to sound. And then piezoelectric effect, when it is coming back, sound wave again becoming electric. Okay, so this is upper part when it is acting as a emitter, electric energy to sound energy. It is called reverse piezoelectric effect. And piezoelectric effect is the action of receiver when sound wave is converted to the electric wave and received by the receiver. So that is called piezoelectric effect. So sound wave has some characteristics. To understand the sound wave, you need to know some few things. what is that? So one is velocity, one is frequency, one is wavelength. Now frequency is very important. Now remember this formula also, d is equal to c by f. So d is here wavelength and c means velocity and f means frequency. So here understand, c is a c for constant also we can understand, though c for velocity, but c for constant also we can remember in this way. So here actually velocity, as I told you, that sound wave goes through a medium, and here our body is a medium. So scientists, when they have seen the velocity or measured the velocity of ultrasound wave in our in human body, so they have seen that there is only minimal difference when it travels through fat or through muscle or through say different other some bursa. So there is not much difference. That's why they have made it a constant figure, 1540 meter per second. So this is the velocity which is applicable when the sound wave is sound wave travels through our body. So in this formula, if c becomes fixed, that velocity becomes fixed, then we know that d becomes inversely proportional to f. Okay, c becomes fixed, 1540 meter per second. Remember, this is not actually fixed. There is some differences, but for the ease of calculation, it has been taken as a 14540 meter per second. So d becomes inversely proportional to f. Means what? Means f means frequency. Frequency is, if frequency of ultrasound wave is low, then wavelength will be more. If frequency of ultrasound wave length is high, then wavelength will be less. So this part you just remember. This is the most important thing. Now here 20 hertz, 20 kilohertz and 20 megahertz. All these things I have written here in a scale. So just remember our audible range is 20 hertz to 20,000 hertz or 20 kilohertz. And from the maximum audible range, if you multiply by 100, then the lowest ultrasound range starts, that is 2 megahertz. So I mean our audible range into maximum audible range into 100, then the lowest ultrasound range starts, that is 2 megahertz, and that can continue up to 22 25. Still now I have seen 25 megahertz probes are there, but 50 60 megahertz also is I mean it is there. So these are called ultrasound waves, ultrasound frequencies. Now here as I told you, just remember from here, if c is fixed, then wavelength and frequency is inversely proportional. Now, why it is important? Why I want to remember this? Because the frequency of the ultrasound wave, it is a hardware characteristics. Like the machine or probe you are using, that probe will produce a certain amount of frequency. That means you can make a probe, or the company can give you a probe which gives a frequency of 2 hertz, or a company can make a probe which can produce the frequency of 20 hertz. So if frequency can be changed at your will, then you can change the wavelength also at your will. Means 2 hertz probe will go to a high depth because frequency is less, whereas 20 hertz probe will go low depth because frequency is more. Okay, now when I'm saying that depth, actually wavelength is here, wavelength means depth. Why? Because wavelength in normally this you can see the picture here, wavelength normally means distance, but when we are talking about the ultrasound beam placed on our human body, then distance means depth, because sound wave is traveling inside the body. That means this is the wavelength. So that means we can understand if the frequency is less, wavelength is more, means depth is more. So a probe which is a low frequency, 2 hertz or 3 hertz, it will show a high depth up to 5 centimeter, up to 10 centimeter, 15 centimeter depth you can see. And if the frequency is very high, then very less depth you will see. Say 15 hertz probe you are using, then maybe 2 centimeter you can see, not more than that. So that is this frequency and wavelength or depth relation comes from this formula. Okay, this D is equal to C by F formula. Amplitude, remember what is amplitude? So amplitude overall, this is the ultrasound wave which is produced by the emitter. The strength of this ultrasound wave is you can perceive in that way that strength is we can mean the strength as an amplitude. We can take the strength of an ultrasound wave as amplitude. So this much amplitude was produced by the ultrasound emitter. Okay, but as it progresses or goes inside the human body, one after another wave is produced, then amplitude decreases. You can see this amplitude is much less than the starting one, and this amplitude is even lesser than the earlier ones. Okay, that means amplitude gradually decreases. Now, why this amplitude is important? Amplitude is important because after a certain fall of amplitude, the ultrasound waves that go inside do not come back, do not reflect and come back to the emitter, which is also a receiver. So the sound waves do not come back because amplitude has gone down. Okay, now why amplitude goes down? So there are four. So this decrease of amplitude, the phenomena is called as attenuation. Okay, just remember the name attenuation. Understand that amplitude is the strength from where the strength of the ultrasound wave which was there at the starting point of when it started from the emitter. Attenuation means gradually amplitude is going down. What are the reasons for decrease of this amplitude? One is reflection, one is refraction, one is scattering, one is absorption. Reflection is actually needed. We want reflection, but which type of reflection we need? Only this type of reflection, which is just coming to the hitting the structure, any structure in our body, hitting the structure, and then it is going 90 degree. It is reflected 90 degrees so that it is received by the probe again. So we will say that the probe is acting as a receiver there, and it will just receive the reflected sound wave. Okay, so this is responsible for the picture production on the screen. So we want reflection, no doubt we want reflection, but still it has an action that it decreases the sound wave further. Okay, so this is also a cause of attenuation. Attenuation of what? Attenuation of propagating ultrasound wave. The wave which is going forward, attenuation of that wave, there are four causes. So one cause is reflection. If here it was 100 and this white represents 30, that means this one is 70. Okay, so understand that this is reflection is also a reason for attenuation. Then some part is refraction. Here it is just wasted. So this is also refraction. You know that two surfaces, surface 1 and surface 2, there in these areas. So the beam which comes here, and due to the acoustic impedance is different of two surfaces, it is the reason for the refraction, but it is completely a waste. Okay, because this is not forming the picture also, and the propagating wave is also becoming weaker. Intensity is getting weak. So reflection, refraction. Third is scattering. So this is also a complete waste. So neither it is producing the picture, it is only making the propagating propagating ultrasound wave weaker. So scattering. And absorption means fourth one is some part of ultrasound wave becomes heat. So this is also a waste or loss. So when we talk about the attenuation, remember we are talking about the propagating wave of ultrasound, and that which is gradually becoming weaker and weaker. That is called attenuation. And the four phenomena, reflection, refraction, scattering, and absorption, remember they are the reason for attenuation. As you understood that all this reflection, refraction occurs from the junction of two surfaces. So these surfaces are called acoustic interface. Okay, these surfaces we call them acoustic interface. And why they are acoustic interface? This acts as an interface because the impedance of two different tissues are completely different. Remember, impedance literal meaning is also impedance means resistance. So resistance of two different tissue. Fat has some amount of resistance. Muscle has some amount of resistance. Blood has some amount of resistance. They all resistance are different. Okay, so two different type of tissues have two different resistance, and as the resistance changes, so these medium between these two this joining point of these two medium, they work as a acoustic interface. Okay. I mean, why the impedance or resistance of tissue is there? So that also have some rule. So we don't have to go in deep of that, but just understand acoustic impedance is due to the density of the tissue, and also it depends on the velocity of the sound with which the sound is propagating through the tissue. Okay, all interface has different amount of reflection. Of course, when the all the interfaces have different impedance, that means the reflection amount also will be different, because some part will propagate through it and some part will get reflected. So with impedance, that amount which is passing through it is also different, and reflection amount is also different. Now this amount of reflection, this will make the picture on the screen. So what will happen? This will make a black and white picture on the screen. So when there is no impedance or no resistance to the propagating ultrasound wave, then nothing will get reflected, and the screen will remain like black. It will produce a black shadow, black color. So then we will call them anechoic. Hypoechoic in is some amount of reflection is there, some shadow is going back, and some white color, it is gray color, gray shade is produced there. So we will call it hypoechoic. And hyperechoic when we will call, when actually though it is a comparative words, but hyperechoic means more and more white. Okay, so when there is complete resistance and all the waves are going back, reflected back to the receiver, and it is producing white dots on the screen, means at least the picture is more white, that produces the white shadow. So then we will call them hyperechoic. Remember here, hypoechoic and hyperechoic, these two are relative things. I mean, there is no specific white color that this much is hyperechoic. From here, hyperechoic starts, and from there, hypoechoic starts. It is not like that. If some area I have to say that this area is hyperechoic, that means the surrounding area is darker than that. If I say that much area only, if I say this is hypoechoic, that same color which I was telling hyperechoic, now I say that no, this is hypoechoic. Why? Because suddenly if I see that the surrounding area has become more white, then I will say this color is hypoechoic. So this is like that. So here you can see these area, these are white color. So this white color means these lines are white. So means these areas are hyperechoic because surroundings are black. Surroundings are black. But this surrounding, if I consider here, then I will not say this is a hyperechoic area because the area which is this part is anechoic. Okay, because this is complete black. This part is complete black. So this is a anechoic area. Okay, this part is hypoechoic area because the surrounding here hyperechoic areas are there. Okay, so this part we will understand while seeing the ultrasound. Application part for, so remember, uh, all the when we are handling the machine, so we need to change some settings and all. So why do we change the settings? So we do everything for resolution. We want to see a structure the best way possible on the screen. So first thing, just understand few things, that bandwidth. What is the bandwidth? So on a probe, you will see this type of numbers. Okay, that means, as I told you, frequency is a hardware characteristics. So here, with the setting, company has made like that you can choose a frequency between 3 to 8. That is also fixed by the company, that you can change the setting like say 3 to 4, 4 to 5, 5 to 6, 5 to 8, like that. You cannot make it 3.1 or 3.5 or 7.8, nothing like that. It is fixed by the company that this much frequency you can use. But here, if it is written 3 to 8, so just to tell you that frequency, lowest frequency produced here is 3, highest frequency produced here is 8. And here the lowest frequency produced here is 2 megahertz, highest is 6 megahertz. Okay, but they will be considered as low frequency probe. Okay. So because up to 6 megahertz, it is low frequency. This is maybe medium frequency, but it is also low frequency is there. So, and what is high frequency? So here 8 to 18. Here lowest frequency is 8 and highest is 18. So this is a high frequency probe. Here, another important thing is footprint or shape. What is footprint? Footprint of the probe. It is a linear probe. It is a curvilinear probe. It is a linear probe. It is a curvilinear probe. Remember, these two are the basic types. There are other types of probes, but these two are important for us also, and others are actually modification of these two. This is a hockey stick probe, but this is also a type of linear probe. Here thing is that this footprint is very small. So, and we are seeing a very superficial structure. So we do not need that big probe, or maybe that we do not have that much place to put the big probe, big footprint of the probe. So we can use this hockey stick probe. But mainly we have only two probe, linear and curvilinear. Linear probe produces a rectangular uh, area of a rectangular view of the area. Okay, and it curvilinear produces a cone shaped view of the area. Okay, curvilinear produces a cone view, and this produces a rectangular view of the picture of the area. Aspect marker. So when I am putting a probe on the human body, and when the picture comes on the screen, I actually do not know just by seeing this picture that this side is his patient's right side, or this side left, right side, which side is what, which side cranial, which side caudal. So these are called aspect markers. Even some probe has a light here. Okay, so company has made like that this aspect marker will match with the left side of the ultrasound screen. So wherever you have put this aspect marker, you know that side matches with this. Means if I have put the aspect marker on the medial side, then this picture is of the medial side. Left side is medial side. If I have put it on the cranial side, then left side is cranial side. Okay, and right side will be caudal side. In this way, so so this thing is aspect marker. Use of aspect marker is very much important because by seeing the picture we cannot say which side is right and which side is left. So gain means brightness. Simply understanding, for simple understanding, gain means brightness. Remember the earlier days black and white TV. So as you use the brightness, here also you increase the gain, picture will become brighter. As I told you, everything what we are doing here while seeing the picture, this adjustment of the knobs is for resolution. Resolution means best picture, best understandable picture. Okay, so here low gain setting, high gain setting, and this is optimal gain setting. Means bright picture is not the picture which I want. Okay, neither bright, neither low gain, dark picture. We want optimal gain setting. So here remember, this one is optimal gain setting and this one is high, this one is low. Both we don't want. So I told you everything is for resolution. TGC, what is TGC? So here also see, this is time gain compensation. This is also like gain but not gain. So just understand in a simplified way that with gain we could increase the brightness of the whole screen. With TGC we can separately increase the brightness of certain part. Okay, say part 1, part 2, part 3, part 4, part 5, in this way. So if we divide the whole screen with these knobs, okay, so in this setting the upper part, so these knobs are in the right side, so upper part is bright, and here in this setting the lower part, the knobs are on the right side, so lower part is bright. Okay, if it is all in the same area, that means knobs are not working. So all have the same here, same output. So remember, with TGC, actually, we can increase the brightness of some depth of our depth of at some depth, which is at that moment I am uh, evaluating that depth. Okay, focusing and depth. Here, focusing and depth. Remember this focusing. So this third part, this focus, this type of one pointer is there on the screen usually on every machine. Some machines have autofocus, so automatically it adjusts, but some machines have this phenomena. Remember, while seeing the picture, evaluating, we have to change this focusing also. The our focus should match the depth of interest. Here the focus, if the focus button is here, that means depth of interest, our structure of interest is at the same depth. It cannot be that structure of interest is here and our focus is here, then picture may not be correct. There are some artifacts which may affect. Okay, so focus should be at the correct depth. As I told you that everything is for resolution. So what is actually resolution? Resolution, there are two types: axial resolution, lateral resolution. Axial resolution means two points are being seen as two, means good resolution. And if two points are messed up and you cannot identify that these are two, so this is called poor resolution. But this upper one is for axial resolution, and when this lower one is for good or poor lateral resolution. Okay, so these are at the same depth and these are at different depths but at the same line. So ultimately resolution means seeing two structure as two structure differently. Zoom is not directly for resolution. It is for seeing a picture in a bigger way. Like you cannot see, you have an eye problem and you cannot see small screen. So in that case, you can use zoom. Picture resolution will not increase. Only the picture size will increase. Okay. So this part is small area of this one. your some basic part only. So let me see that how much you have understood these basics of ultrasound. Just open quiz.com. Let's see. Just open your browser, Google, and write quiz.com. Then we will proceed again. Write quiz.com. Here it is written, upper part, quiz.com. Just quick 6 questions. And after writing quiz.com, just a minute. Enter pin code 952111. Okay. Enter quiz.com and write pin code 952111.
Toilet
Dr.
hacker.
DK. Dr. SD.
Another 3 people should have joined. Please join.
Why?
Just few questions. So let's see.
Quiz.com. Play and create.
Which is a wrong statement about USG. Lowest USG frequency is equal to the highest audible frequency.
So this is wrong. 100 times more.
Which is wrong about USG. For abdominal wall ultrasound, 2 to 5 MHz curvilinear probe is necessary. Which is false about attenuation of US beam. Attenuation depends on the depth of beam travel and not on tissue type. For best resolution during USG, we may have to adjust all of the following except zoom.
Others are for best resolution.
Which is the optimal gain setting picture among the three?
Okay. So just a minute. Okay. So we go to the presentation again. Where is that? Okay. So Hmm. So, as we understood the first part, so now step by step for a when we are going to evaluate a patient with ultrasound, do the musculoskeletal ultrasound. So first, what to do? First, switch the machine on, then choose the probe. Okay, so you have to first make the decision that whether you are using the linear probe or curvilinear probe. Then position the patient. So position is also important. I mean, whether say you are seeing a shoulder, whether shoulder remains in neutral position, abducted position, or in different other position, internal rotation, external rotation. So that you have to decide. Then mind the aspect marker before putting the probe on the human body. You just have to see that which side is aspect marker you are putting on which side of patient's body, in the medial side or lateral side. Then apply gel. You have to apply the gel so that between the skin and probe there should not be air. Okay, decide axis and start scanning. Remember that whichever structure you want to see in the human body, you have to have an idea that on I mean in which area you should be expecting to see that structure. Like you want to see a muscle, you should be knowing that muscle's origin and insertion, in which way it is going. Okay, or tendon, so from which way it is starting and where it is inserting, you should be knowing that. Because otherwise with ultrasound, it is not for finding a structure. You see the picture and then you start to find. It is not like that. So first you expect the structure should be there, then only you can understand the normalcy or abnormalcy. Okay, so first and when you know that structure of interest, then you know that which axis you are holding, either the probe, either the in the short axis of the structure or in the long axis of the structure. Then start scanning. Then palpate the anatomical landmarks. So while imagining that in which way that structure is going, you should, I mean, if possible, if applicable at that area, you should palpate the anatomical landmarks, so that with first positioning only you get the right area. Okay, then start adjusting. Then when the first picture comes on the screen, then start adjusting gain, depth, focus, frequency. So four things, remember: gain, depth, focus, frequency. But focus can be autofocus, so gain, depth, frequency is must. But if focus is also in your machine, it is required, then you have to uh, adjust that: gain, depth, focus, frequency. Anisotropy. So remember, there are some artifacts. Without their knowledge of these artifacts, you may diagnose a normal structure as an abnormal structure. Okay, artifacts means what? Artifacts means it shows some abnormality on ultrasound picture, which is not due to the disease, but due to uh, your holding of the probe, or say due to the machine, due to the ultrasound issues, due to the ultra machine issue, or say as you are holding your the procedural issue. There may be multiple different issue, but not actually a disease entity there, but it is showing a abnormality. So that is artifact. Okay, so anisotropy. What is anisotropy here? So remember, this area is white. This is a hyperechoic area. Okay, this is a hyperechoic area. But in this area, this has become black. So this is black, this is white. Okay, remember this is a tendon and this should be white. A normal area should be white, but this is looking like a black area, means hypoechoic. This is the hyperechoic and this is hypoechoic. So it has become hypoechoic. So if a tendon is diseased, it can become hypoechoic. But if the technique of seeing the tendon is not correct, then also it can become hypoechoic. So here, so in that case, when the technique is not correct, then the hypoechoic picture it shows, that is called artifact, anisotropy artifact. Okay, so here just remember, as say the structure within our body, it has a curved surface. Inside our body, the surface is curved. Now this middle part of the ultrasound wave, you see the ultrasound wave is hitting the surface and again going back to the ultrasound wave, and then it is producing a picture. Okay, but when it is hitting a periphery, then it is not going back to the ultrasound wave. Some waves will go out, and here some waves will go out. So in here the whole periphery has the same ecotexture, and this part is not diseased, this is same as other parts, but still the sides are being shown as hypoechoic and the middle part is shown as hyperechoic or normal. So that means what? That means it is just because the sound waves are not getting back to the transducer, to the ultrasound probe, that's why it is showing the different color and not due to the disease. So what we will do to correct that, we will see this whole surface part by part. First we will see this area, then we will see this area, then we will see this area. So what we will do, next time, second time, we will put the probe in this way. Then third time, we will put the probe in this way. Okay. So we will rotate the probe in this way. Okay. So same thing, same curve thing. This curved surface can be in a opposite another axis. If it is an x-axis, it can be in y-axis also. So it can be like this also. Okay, in another axis, the curved thing. So in that case, what we will do? So here, as we have slanted the probe in this side, we can make it slanted in the opposite side also. So here it is a slanting, and this side also it is slanting. So in that way also, the anisotropy can be tackled. So this is a way of tackling which is called heel-toe maneuver. Heel-toe maneuver. And this is a way of tackling which is called fanning, fanning maneuver. Okay, so these two maneuvers are for tackling the anisotropic artifacts. So heel-toe maneuver and fanning. So there are multiple other movements of the probe. One is called sliding, one is sweeping, one is rotating, one is heel-toe and fanning, I have told. Some other maneuvers are there like fishtailing, gel standoff and compression. So what is fishtailing? Remember, I am seeing a structure, say this is a structure, a muscle say, and I am seeing a structure in this way, in a long axis. So if after seeing the structure in a long axis, now I want to see in an oblique axis, and I just keep one end fixed and just move another end. So this is called fishtailing. One end fixed and other end is moved. It can be any end. Okay. Gel standoff. So you are giving a too much amount of gel and then seeing that structure from a distance. Like this is the surface. You are putting some amount of gel here like this, and then the probe is here. Okay. Then how the picture will come on the screen? So picture will be like oh. So picture will be like here is the tissue, up to this much is the tissue, and then there is a gap area of gel. Okay, then your probe is there, so picture starts from here. So first you see a gel layer, and then you see the tissue layer. So that is called gel standoff. It is important for if the procedure is to be done for a very superficial structures. Okay, others uses are also there. Compression. So compression, why it is used? So it is used for understanding which one is artery, which one is vein. Artery is cannot be compressed easily, but vein can be compressed easily. So it gives a corroborative evidence that okay, this is artery, this is vein. Otherwise, under ultrasound, it can look just same. Okay. Doppler technology, remember, as we understood that ultrasound has been our eyes. We are seeing as if it was our eye. But if it sometimes works as in our ear also. So how? So if I am just standing on the platform and one train is coming and one train is leaving. So my ear can say that which train is actually leaving the platform and which train is actually coming towards the platform, because the sound wave, one comes and one is going. Okay, so here also ultrasound probe can tell that, because the sound wave which was hitting one RBC, okay, that RBC has gone here, say. So now the reflected ray, that reflected ultrasound beam will come from a distance. So in that way, that whole technology, I'm not saying you here, the main thing is that it can tell that the blood flow which is coming, the blood flow, it is coming towards the probe, or the blood flow is going from the probe. Okay, for going away from the probe. So this much it can say. So color, mainly this Doppler technology is used for two different things. One is just to understand if it is a vessel, means blood is flowing through it or not, whether towards it or towards the probe or against the probe, that we are not saying. Only it is a vessel or not. So that is seen by powered Doppler. And colored Doppler says that whether it is coming towards the probe or going away from the probe. In that we can know that whether it is artery or vein. Okay, so as a pain physician, we only want to know whether it is a vessel or not. Artery vein is not that important, because we want to avoid both artery and vein. Okay. So here ultrasound probe is acting as if it is our ear. So here, so there are multiple other artifacts. I talked about these two artifacts, these artifacts like anisotropy in the basic ultrasound. Otherwise, there are multiple other artifacts which are, some are there in Doppler artifact. So random noise and mirror artifact. So random noise, remember, if you increase the gain in Doppler artifact, in Doppler setting, then this type of color may come. So this is called random noise. These are not the same as increased vascularity. How to differentiate it? Means in vascularity, if it is a vessel, say increased vascularity, too many vessels are there, too many blood supplies, too much blood supply is there, then same color will be reproduced at the same place again and again. But random noise is not like that. It is like sometimes it is black, it is blue, sometimes it will be yellow, sometimes it is red, and in the same area picture also will not come the color. So in that case, it is called random noise. Treatment is by decreasing the gain. Okay, most of the Doppler artifact is treated by decreasing the gain. Mirror artifact, so here vessel is there outside the superficial to the bone, and deep to the bone also we are seeing it is acting like a mirror. As we know that ultrasound beam cannot pass through the bone, so it is deep to the bone. So that means there actually ultrasound beam is not going there. We cannot see anything here. So this is a mirror artifact of this upper superficial one. Okay, so this is also by decreasing the gain. So there are multiple other artifacts. I'm not describing all these things: reverberation, blooming artifact, motion artifact, aliasing. So all these things are treated by decreasing the gain. Tissues under USG, remember how it looks. So skin, this part is very important. I hope all of you know the initial things, that how it looks. So this part is skin. Okay, this part is skin. So how it looks here, remember, when we want to if we in any case we want to see only the skin, then it is not possible with these probes. Okay, we need those used by dermatologists. Those probes have frequency of 50 hertz, 60 hertz, if we want to see the layers of the skin. So here we are seeing the skin. So remember, I just skin subcutaneous tissue together I showed you. Actually, this is skin. Okay, this hyperechoic area, this hyperechoic area. So skin is this hyperechoic area, only small part. This hyperechoic area is skin, and then comes fat in the subcutaneous fat. So a first layer is skin, then comes subcutaneous tissue. So this much is subcutaneous tissue. Okay, this much is subcutaneous tissue. So remember, subcutaneous is hypoechoic, and these are some hyperechoic stria, hyperechoic stria within the fat layer. Always remember, differentiating this layer and muscle layer sometimes becomes a bit tough. Okay, but this third layer is muscle layer. Okay, so after seeing for few few months, you will be seeing it very nicely, but try to always see carefully, that so that you can differentiate. So this part is fat, hypoechoic with stria, and below that, that is the muscle layer. So how muscle layer is seen? Remember, muscle layer, either you can see in a long axis like this, you can see different hypoechoic lines with the parallel. So this is like a fibrillar structure. You can see the fibrils. But then remember here, one important thing, these white colors which are going like a parallel lines, they are not the muscle fibers. They are coming from endomysium, perimysium, epimysium. Okay, and the black area in between them is the muscle fiber. Okay, so this picture is coming from the long axis view, because it is along with the fibers. Our probe is kept along with the fibers, so we are seeing these fibrils. Okay, this hyperechoic parallel lines. And if we keep it in a short axis, then we will see the cross section of this parallel lines. Okay, so this is called starry night appearance. Okay, this starry night appearance is the nothing but the short axis on the muscles, short axis picture of the muscles. Then comes, so muscle can be unipinnate, bipinnate, so that is not much important here. Tendon. So what is tendon? So you remember, from muscle to bone, muscle attaches to a bone after becoming a tendon. So all tendons actually they form a bird beak appearance. So this is called bird beak. Okay, this is called bird beak. So bird beak appearance you will see when they insert in the bone. So this is called bird beak appearance. And how tendons are seen? So these are hyperechoic and fibrillar structure. You will see fibrils here, fibrillar structure, and it is hyperechoic. So normal tendons are hyperechoic and fibrillar. Okay, and they join on the bone as a bird, with a bird beak appearance. Ligaments, they also have a fibrillar pattern. And hyperechoic. Only difference is that they are from bone to bone. They start from one bone, goes to another bone. And remember, since they go from one bone to another bone, they are deep structures. Whereas tendons, they come from muscle to bone, so they are not deep structures. They are, I mean, muscle layer is much above the ligament layer usually. There can be some uh, exceptions also. Nerve. Nerve, remember, it has a typical picture of honeycomb appearance. So this one, honeycomb appearance is the appearance of nerve. What is honeycomb appearance? So black and white, small. So it is like this. One is black, one is white, one is black, one is white. So these are called honeycomb appearance. Here also, likewise, as the muscle I so told you, these, if I see in a long axis of the nerve, then we will see this type of fibril structures. Okay, of course, here also it is, I mean, like white and black, both lines are there. So remember, here also black lines are actually the nerve fibers. Okay, and what are the white lines? White lines are nothing but perineurium, epineurium, endoneurium. Okay, nerve, actual nerve fibers, fascicles are actually the hypoechoic one, black one, and these white ones are the coverings. White one are the coverings. So here also white are coverings, and others are like black one is the nerve fiber. So you can see this lower one is the long axis and upper one is the short axis of the nerves. And remember, it shows honeycomb appearance. Remember, this is the cartilage. As I told you, two types of cartilage in our body. One is fibrocartilage and one is hyaline cartilage. So whenever you are on a joint, or you are seeing a joint, always remember there can be both the types of cartilage should be there, but the articulating surface should have a fibrocartilage, hyaline cartilage. Articulating surface should have a hyaline cartilage. So this is the black hyaline cartilage. Hyaline cartilage or articulating cartilage, articular surface cartilage, these are completely, this gives a anechoic picture. They do not, acoustic impedance is so low that ultrasound beam completely goes through it and directly hits the periosteum here. Okay, so these are the bone margins, bony margins or periosteal bony margins. Okay, and above that, this black line is the cartilage. So remember, if there is some fluid accumulation here, then fluid will also be black and this cartilage will also be black. So it may be a difficulty to understand which part is cartilage and which part is fluid. This part is your fibrocartilage. Remember, fibrocartilage is hyperechoic, not like hyaline cartilage hypoechoic. But only important thing is ultrasound beam is not stopped by fibrocartilage. Ultrasound beam can pass through and through and can hit the bone here. So you can see this hyperechoic structure, but here you can see the bone below. So you know that this is fibrocartilage. Okay. If it would have been a bony structure, you could not have seen anything like that. So wherever you see a bony margin or bony margin, remember there it will produce a acoustic shadow and you cannot see anything below. Okay. So this part is fibrocartilage. Fibrocartilage is not on a joint surface. It is this is for giving a smooth surface to the overlying tendon. Bursa. So bursa, you cannot see a bursa where there is no fluid. When there is a fluid, so then only you can see a fluid filled bag like picture. So this is a fluid filled bag. Okay, so then we will say this is a bursitis or fluid filled bursa. A normal, some bursas in our body can have a small amount of fluid, like say 1 ml, 0.1 ml, 0.5 ml. So this much is possible. Otherwise, without fluid, you cannot see a bursa. And the location of bursa should be known to you. Otherwise, you cannot search a bursa or anywhere fluid accumulated, you cannot say that this is a bursitis or bursa. Bursa exact areas are there in our body, and we know that areas. Okay, so vessels. So what are the vessels here? So these are the vessels here. Okay, these are the vessels. So here you can see, if I put a probe pressure, then one vessel is there, another is not there. Okay, so I mean, this area we are seeing. Okay, this area. So what we are seeing, so one vessel is there, but another is not there. Means the vessel which is not there, that is vein, and which is there, that is artery. Remember, for ultrasound guided intervention, principle wise, whenever we do any intervention, we can do in plane or out of the plane. In plane means when we so this is the ultrasound, say ultrasound picture. So here the ultrasound beam is just flowing perpendicular from the beam, it is going straight. So if the probe is started from one side of the probe, one corner of the probe, and it comes out through another corner of the probe, then it will show picture like this. The whole needle, you can see the whole beam is going through and through the probe. Of course, it will not go through and through because it cannot pass through the metal, but it is within that plane the beam is passing. So you can, this is called in plane needling. But you think the probe is in the same way, but your needle is started from here, and then you are reaching to the depth, then you can see the needle like a cross section only. So these beams are going like this, and needle is from one side, so it is like a cross section. So this is called out of plane out of plane intervention. So if you see full needle, when the tip is seen, tip of the needle, for seeing the in plane needling, the tip is important. We must see the tip of the needle. And out of the plane, remember, only the superficial cases we do in out of the plane, because it is risky, because we do not know where is the tip. So you may think that, okay, I am seeing the needle part, this part is in the right place, but that may not be the tip. So in plane needling wherever possible is advised, and not the out of the plane needling. Okay. Now this part is basic part. Then I will talk about few things about pathology. If anyone has any question in this part, can ask me. Okay. In common pathologies, so remember, though in our body, I mean, all in different parts, there are so many tendons, so many bursa, so many nerves. So we can have multiple different tendinopathy, multiple different neuropathy, or say multiple entrapment neuropathy, or anything like that. So, but while we are doing the ultrasound, the few common findings are always important, because if a joint is involved, or say a tendon is involved, no matter which tendon is involved, after getting involved, or the pathology when it starts, it gives the same picture. Of course, it will be a bit different as per the that specific joint, but most of the things are common. So here what I'm saying, that all tendinosis or all tendon tear have some common finding. Avulsion, calcification, spar, they are common finding. And then ligament sprain or tear have some common finding. Bony degenerative changes or effusion, they are common. I mean, these pictures are same. Inflammatory changes in tendon or joint, it is also similar, produces a similar picture. Nerve entrapment, loss of muscle mass, so these will produce a similar picture. So I tell you few things here. Before you see the specific areas, or you think about specific pathologies, you should be able to understand some common things. So here what I told you, bird-beak appearance. So normal tendon under ultrasound, how it looks. So normal tendon looks hyperechoic and fibrillar. So these are hyperechoic areas. Okay, hyperechoic. I am seeing in a long axis, and hyperechoic and fibrillar. So this is a short axis. So this is like, this will be like this. Okay, so short axis and long axis. But here the fibrillar structure is very clearly evident. Here hyperechoic is clearly evident, but fibrillar will, it will be dot dot like. So this is also the same thing. So hyperechoic and fibrillar, and all tendons attached to the bone, insert to the bone as a bird beak appearance. No matter which tendon I am talking about, all are having a bird beak appearance. Okay, so this is a normal thing. So whenever there is a tendinosis, what happens? These tendons, these tendon areas, they become thicker. So here actually you may not be able to understand that whether it is thick or not. So, but then when you compare with the opposite side, you will be easily understood. It can be easily seen that it is thick. So here actually it is thick. I can understand. So it should not be that much, it should be like this. So this is thick. And second thing, fibrillar pattern is lost. You see that this area fibrillar pattern is not there at all, and replaced by hypoechoic changes. Tendon thickening is seen. So why this tendon becomes thick and why hypoechoic? Actually it becomes edematous and water is absorbed here. So if water is hypoechoic or say anechoic, so some anechoic part is mixed with the hyperechoic, so it becomes hypoechoic. And since it is becoming edematous, so thickening, I mean the size also increases, nothing else. So this is a finding of tendinosis. So this is a finding of tendinosis. Then comes tear. So what we call as tear? So see, so as I told you, bird beak appearance. Okay, but if we see carefully, here there is some tear. Okay, this black thing should not be there. Here there is some tear. So same tendon. This is a long axis view and this is a short axis view. So we are seeing this tear. Okay, and another. So this tear actually it is not towards the bony surface. It is towards the upper surface. This is one muscle. This is one muscle. So it is towards the upper surface. Actually, it is a bursa area. Okay, so this is called bursal side tear. Okay, but the same way here there is some tear, but it is towards the bone. This is short axis and this side is long axis, long axis, and this is short axis. But this is towards the bony side. Okay, so this is called articular side tear. Articular side tear, bursal side tear, and sometimes there can be a mid substance tear also. Actually, this is mid substance tear. This is articular side tear. This is bursal side tear. Okay, so these are different types of tear. Of course, there can be a tear means some amount of fibers are torn. Some amount of fibers are torn, and there can be a full thickness. So these are all partial tear. Remember, all these tears are partial tear. Some fibers are torn, but not all. Now, second part comes as a complete tear. Complete tear or incomplete tear can be full thickness tear can be complete or incomplete. Full thickness means what? Partial tear, you understood, some fiber it was torn. Now full thickness tear means when from the bursal side to the articular side there is a connection. So this is called full thickness tear. But this is incomplete. Why? Because this connection at some place, but other place fibers are okay, because this part is also there. I mean, there is a continuation. This tissue is continued, though there is a connection at some place, but it is continued. When I see in short axis, I can see that okay, some this area maybe there is a continuation in this area, but then this area is completely normal. Okay, there is no problem. So this is full thickness but incomplete. But if I see another tear which is like there is no continuation, okay, that then we will say that this is full thickness also, but there is no continuation between the proximal side and distal side. So this is complete tear. In this complete tear, uh, patient will have complete loss of that movement, that specific movement of the part of that part. Okay, so though if there is partial tear, sometimes up to partial tear we treat, but if there is a complete tear, full thickness tear, we always send to the surgeon. But of course, some patient may say that I do not want surgery, you try. Though complete, if there is a full thickness complete tear, we cannot treat. We will say that we cannot treat. But in all other cases, we can say that, okay, we will try to regenerate. Tendon sheet and paratenon. So, all tendons have a tendon sheet, and sometimes in some areas tendon sheet is not there. Tendon sheet actually usually it is there in the different tunnels, say carpal tunnel area or say tarsal tunnel area. There the tendons in most of the tunnel areas, it is covered by a sheet that is we call tendon sheet. So if there is a tendinitis, so there is a fluid in the inside the tendon sheet. Okay, so this also gives a common same finding. So here footprint area. Just yeah. Here let us see another thing. So avulsion injury. We will see an avulsion injury. So avulsion injury is also an injury which shows the same picture under ultrasound. So here, of course, some related X-ray picture is also there. So here you can see avulsion injury means what? When there is a chip of the bone is also avulsed. So this is the bone chip avulsed. Okay, so here with ultrasound also you can see some part of bone chip avulsed. Okay, here it's not very clear. Here some part bone chip avulsed. Okay, so these pictures are same. When you are seeing a tendon injury and if you see that there is a bone chip which has come out, then you should be diagnosing it as a avulsion injury. Okay. These are, of course, most of the time acute injuries. Now, calcification. All calcifications will give the similar picture. Calcification, wherever it is, doesn't matter. Now, calcifications, though it will give similar picture, but calcification can have different stages. Like early calcification, late calcification, complete opacity is there or not. So it depends. So here you can see that this is early calcification and this is late calcification. Here completely opaque. That's why this acoustic shadow, it is completely black. No ultrasound beam is going down. But here this is soft calcification till now. That's why some beam is going inside. Okay. So this type of calcification we will see inside the tendon. Okay, this part is completely tendon. So inside the tendon we are seeing the calcification. So this is a similar picture. Another thing is spar. So remember, calcification is within the tendon, whereas the spar is actually coming a bony outgrowth from the a bony outgrowth actually. Okay, it is not developing in the tendon. It is developing from the bone. Okay, it is developing from the bone. So this is one spar. So with ultrasound, we are seeing this type of spar. Most of the spars are seen from the calcaneum. Okay, calcaneum either from this side or from this side. Okay, so here also we can see. So these spars are seen in the similar way. You will clearly see that bony outgrowth is there. Okay. So these are spars. So ligament injury or tear, I have already told you muscle tear. Now ligament tear, as I told you, ligament is a deep structure. It is from bone to bone. So here the ligament should be there, and it is also normal fibrillar structure. There can be a swelling, and normal fibrillar structure is completely not there. So whether a ligament in acute case, you will get this type of picture. You in chronic case, you may see that okay, there is no swelling, only the fibrillar structure is not there, but you may have some confusion that whether it is there or not. So you can go for dynamic examination. You can try to make the joint a bit more wide. So if it is possible to make the joint wide, that means there is ligament rupture. So here there is a ligament. You can see this is normal. This is normal. Clearly you can see. But here, there it is maybe acute injury. There is so much swelling and all, and there is hardly any fibrillar structure. No fibrillar structure. Okay. Here some part is good. This part, but this part is not good. Okay. This part there is some problem in this area. So this is a ligament injury. So here also some part we can see, but other parts we cannot see. So maybe these are all ligament injuries. Okay. Bony degenerative changes. There are multiple bony degenerative changes. So cortical erosion, cortical break, osteophyte. So osteophytes, remember, it is very common. These are osteophytes. Okay. Osteophytes are like in osteoarthritis, most of the time we see. These are bony outgrowth, different from spar in the sense that spars are, so these have specific areas. Spars are seen only in the calcaneum, or say specific spars are there, which are specific areas are there. Otherwise, I mean, material is same only. They both are bony outgrowths. So here, cortical osteophytes. Osteophytes are mostly seen in long bone endings like femur, or say other areas, say spine, vertebra. So these are osteophytes. Okay, these are osteophytes. So bony outgrowths. It should be like this. It should have gone like this. Okay. These are called cortical break. Cortical break is a mostly used term in trauma, acute injury. Okay. Whereas in arthritis, we say cortical erosion. So these are called cortical erosion. Break is a clear line. Break is a clear line. But similarly, when the bony cortex when the bony cortex is disrupted, so that is what. So these are similar pictures. Cartilage loss grading. So remember, there are multiple types of cartilage loss. How much is lost, you can see. So here grade 0, normal cartilage. Here grade 1, grade 2, grade 3. We do not need to do grading. This is radiologist's job. But at least we should be able to identify that how much, in that way, that mild, moderate, severe, how much loss is there, so that we can note in our document in our notes. Effusion. So different area effusion is giving a similar anechoic picture. So this is a anechoic picture, effusion. Okay. So this is in a joint. This is also in a joint, but then anechoic effusion picture is a similar thing wherever it is. Infusion may be degenerative, may be inflammatory. So remember, if it is an inflammatory effusion or not, how you can see. So here, ultrasound not only giving the anatomical change, but showing the anatomical change, but giving a hint to the background pathophysiology also. Means itis means inflammation. So whether it is a synovitis, or say arthritis, or say I mean tendinitis, which is causing the inflammation. So how do we know it? We see two things. One is synovial hypertrophy, one is neovascularization by ultrasound only. So, and with anatomy, it gives some physiological evidence also. So as we give the Doppler here, we see increased vascularity. You should be measuring with other non-infected area also. From right side there is a problem, you measure with you compare with the left side also. Okay, so remember, do not confuse it with the random noise anisotropy. Okay, not anisotropy, artifact, random noise artifact. Do not mix up. So this is called neovascularization. Due to neovascularization, we are seeing in color Doppler increased vascularity. So whether it is around a tendon, inside a joint, or inside a bursa, the picture is same. Okay, so this is neovascularization. And another thing is synovial hypertrophy. So what we will see? We will see some cloudy picture, cloud type of thing, cloud in the sky type of picture inside the joint, in between the fluids. Okay, so here this part is anechoic fluid. Okay, this part is fluid, we can understand. This part is anechoic fluid, but around that what? So these cloudy pictures, these are synovial hypertrophy. This is in a joint and this is around a tendon, but this cloudy picture is same. This cloudy picture is same. So these are called synovial hypertrophies. This tells us that this is not a degenerative condition. There must be some inflammatory pathology. Nerve entrapments. So all the nerve entrapments, wherever it happens, remember, there is a, so what happens? Honeycomb-like appearance to, this is normal, honeycomb-like appearance to irregular blurred appearance, hypoechoic and swollen. Okay, so here, so you can see this one is nerve, this one is nerve, but suddenly there is a compression. This black one suddenly got compressed. So where we will see what? So this is the proximal area, this side is distal area. So suddenly this proximal area, this the normal honeycomb appearance, or say this fibrillar this area, structure, that is not there. Normal neural appearance is not there, and it is swollen. It is a bit swollen. This part is normal, but this part is swollen. So proximal part becomes swollen and hypoechoic. Of course, you have to measure with more proximal areas so that you can compare. So, or even with the opposite side, you can compare. So this is hypoechoic and swollen. And many times there is a measurement method also. So whether it is swollen or not, so normal measurement, say 4 millimeter to 6 millimeter, if it becomes 7.5 millimeter, then you know that okay, there is a swelling. So this finding is also common in nerve entrapment. Loss of muscle mass. So this is like comparing with the opposite side and measurement the cross section area. Differentiate tendon versus nerve. Many times it happens that tendon and nerve both are lying very close to each other, give a similar picture. So tendon is also hyperechoic, and there can be some areas of hypoechoic muscle fibers part, and nerves also in some area it can be completely hyperechoic. Rather than honeycomb, it can show some hyperechoic picture, and it's sometimes confusing. So how you will understand? So go proximally. One will become muscle and another will remain nerve. Maybe size will become a bit more or small, depends on differentiation is there or not, but then it will never become muscle. Or second part is anisotropy. In nerves do not show that much of anisotropy. Mild anisotropy it may show, but it will not show as anisotropy shown by the tendon. Means as soon as you see on the tendon, it can be black, it can be white. Just you move the probe in the wrong position, immediately it will become black. But on nerve, either you put in right or wrong position, it will not be, this anisotropy of becoming black and white is not that pronounced. So this is to differentiate. Now understand, with ultrasound, another thing we always try to use, that is dynamic examination. Now dynamic examination with ultrasound, why we use? For better visualization. We move the picture so that we can visualize better. Some structures is seen better when you move, like say small nerves. If you do not move, you may not be able to understand from a static image. So better visualization. Impingement, whether there is an impingement or not, patients complain is like that when I am moving there is a pain. So you can put the probe and make the patient do the same movement to see that what changes occur in the body. So that is the for diagnosing impingement. And same thing, similar thing is snapping. Here also patient with pain, patient says that I have a snapping sensation, a sound like sensation. So in that case also you can go for dynamic examination. Gapping of joints, if there is a ligament tear, you can try to make the joint gap a bit increase, and you see under dynamic examination if it is really increased in one side and other side is normal, then you know that this part dynamic examination gives positive result. Subluxation of nerves, so that is also with dynamic examination only you can understand that okay, this nerve is subluxation is there. In the flexion position subluxation is there, but in extension position it is not there. So this movement you can see under with dynamic examination of ultrasound. So this is the major advantage under ultrasound. Osteofibrous tunnel, remember in anatomy, as we know, osteofibrous tunnel most of the time it is the nerves, blood vessels and tendons, they all go under a tunnel, inside a tunnel. And how tunnel is formed? Above it is covered like a umbrella, like a with a retinaculum, and below side it will be bone. So it is most of the time in all the tunnels in our body have the same shape. So below it is the bones, upper part is by a retinaculum, and in between them all those things are going through this tunnel. They are neurovascular bundle and tendons. So as I told you, there are so many artifacts: acoustic enhancement, acoustic shadowing. What is acoustic enhancement? Enhancement is if there is a, I'm seeing a picture, say I'm seeing a picture of, I mean, our body structure. I have put the ultrasound like this. Okay. Now here there is some tissue and there is one vessel here. Again, here there is some tissue. Now ultrasound beam of 100 intensity is coming, emitted from here, 100 intensity. Now here 20 is absorbed, 20 is absorbed. Then here the same beam has become intensity of 80, 80. Here there is a vessel and it has absorbed only, I mean, all the surrounding together. Since it is not giving any impedance, it is absorbed only 2 intensity. So here the beam is 98. So suddenly you will see at some area it will be more white and this area is black. Maybe this whole tissue is just the same, but still one part becomes more white and one part is black. Why? Because of this area, due to the vessel which did not absorb the ultrasound beam at that area, upper area, proximal area. So this proximal area, if it absorbs less, this will cause distally acoustic enhancement. And if it I mean, it is some area is there which is bony area, say this is the probe and this is the bone and nothing is going inside. So we will see the margin of the bone and then all black. So that is called acoustic shadowing. So these are why we are saying all artifact, because these are showing as if it is abnormal in these areas, but these are not abnormal. These are normal phenomena of ultrasound imaging. So this is acoustic enhancement, I told, acoustic shadowing. There are many other artifacts: aliasing artifact, bayonet artifact, beam width artifact, blooming artifact. So you can read them. If I talk about all these things, then you will, I mean, it will take so much time. So acoustic enhancement, just to show you, this is acoustic enhancement. acoustic shadowing under the bony osteophytes, you cannot see anything, or bony margin, you cannot see anything. That is bayonet artifact. Like we put a stick in the water and we can see the bending of our stick. The same thing, when we put a needle in the effusion area, we can see the bending sometimes. So this is called bayonet artifact. Double aorta artifact. So this is also possible with a curvilinear probe. Our aorta may look two, but we know that it is one. So with repositioning and all, changing the setting, it can become again same. Reverberation artifact, while we are doing a aspirating a effusion, so we can see multiple needles. We have put one needle, but picture may be like this. Then remember, the uppermost one is the actual needle, and others are all artifact shadows. These are not needles. So these are reverberation artifact. Beam width, so these are Doppler artifacts. So most of the Doppler artifacts are treated by decreasing the gain. Aliasing artifacts, so this tells us why the focus area should be at the level of our area of interest. Here in the left side, you see focus is much higher than our area of interest. So picture produced here has shown the black spot and white spot overlying each other, but it is not overlying. When this thing is corrected and focus it at the area of interest, then only white part is showing and black one is outside. So this one giving the correct picture. Like this blooming artifact, color brute. So these artifacts are treated by most of the time with decreasing the gain. Electrical. So electrical interference, this one also we see sometimes multiple different uh, different electrical gadgets you should not keep on the ultrasound machine or very nearby. It can cause interference. Oh, last thing. So before labeling abnormal with ultrasound, always consider congenital variation. There are multiple different variations. While we are doing ultrasound, we are seeing that it is possible. Wherever we do not, one nerve, we think that it should be there, but it is far from there. It is possible. So you compare with the opposite side. Most of the time, one person who has the congenital variation, this variation is present in the both side, and compare with the opposite side. So these two things you remember. And common examination protocol, while we are checking a structure in the body, remember, cover the full area in both axes. Footprint for tendon insertion, footprint area for tendon insertion, it gives us a degenerative pathology. Critical zone, which is critical zone? It is 3 to 4 centimeter proximal to the insertion, not at the insertion, proximal to the insertion. So degenerative or trauma related. If there is a critical zone rupture, it can be degenerative or trauma related. Or myotendinous junction. Up to myotendinous junction, we must see. So footprint, critical zone, and myotendinous junction. Mostly it is trauma related. Dynamic examination we should do wherever applicable. We should stretch the area. Doppler wherever indicated. And grading we should try to do, at least the severity we must document. Size and localize. So we may write it on our documents, the sizes of the TR or anything like that. Okay. So this much. And any question anyone has? So this is the starting point of our ultrasound course, and the common findings should be very much understood. Then only you think about the uncommon things, or for one by one things, because common things are just okay. One this part. Please open your quiz.com. Another 5 minutes. Play now. So today actually class has become a bit 15 minutes longer, but usually we complete by 7:30. Today we was of course started 5 minutes later. Please enter fast. I'll So this is the pin code 995876 at the quiz.com. Just open, enter this. Okay, I'm starting. Those who have not joined, not joined. Share computers. Time game.
Quiz.com. Play and create.
Touch the
G
anechoic area.
joined. Y joined.
Touch the hyperechoic fibrillar structure. Yellow marked area represents subcutaneous tissue. What is wrong about peripheral big nerve visualization under ultrasound? Too much anisotropy elicited. Calcification is commonly associated with acoustic shadowing.
Final question. Double points.
Intervention is being done under USG guidance. It is a In plane technique.
Third place. That boy. Second place. Jolly woman. And the winner is Y.
So, who is Y? Who is Y? So,
That's
someone is
Dr.
Y.
Deep.
Okay. So, yeah. Okay. Anyway, um, who is Y? I could not get it.
Dr.
Oh,
Deepti, sir.
oh, Dr. Lakshmi. Okay, okay,
Yes.
okay. Okay. Congratulations. Okay, you understood everything very nicely. So anyway, so good night for today. You please see the presentation multiple times, at least 2 times, so that you understand the basic part very nicely, so that next classes becomes much easier to you. Because though it is a 6 months course, but only one day per week for 2 hours is not sufficient for understanding everything nicely. So you have to give your own effort also. So you must understand, must see multiple times and memorize these things. Then you will get the other parts easier. Okay. Thank you.